meanwhile, they fix it. Basically, me and Melek, we are really good friends. And we didn't know that we were going to be together actually in Cairo. And each one of us prepared a presentation separately. And then we looked at the agenda, and actually we are in Cairo together, and we are presenting one after the other. And we had very technical presentations, and we said, sorry, that's not fun. Let's. Hello? Hello, okay. So we decided to go through a more interactive presentation, and which is basically make you think as Fulbright, and we would love to hear your thoughts. This is an idea that we had in mind, me and Melek, and we discussed it for a long time, and we decided to basically share it with you.
So before we get started, this is where it all started actually. I made Jabber in the waiting room for the interview program at the Fulbright in 2011. I didn't know the person. We just sitting next to each other. It's like, okay, what are you doing? It's like I'm actually a doctor, just starting my residence surgery, and
I'm a veterinarian. I really like animals, and want to specialize in exotic animals.
So, and here we come now.
Today.
So today I'm a scientist and a researcher and fellow at the Imperial College London. I was actually also an instructor and a faculty lecturer at MIT and Harvard Medical School.
I'm into preventive veterinary medicine at the UC Davis School of Veterinary Medicine, specifically with the Center of Animal Disease Modeling and Surveillance. And we actually co-founded with other Fulbrighters in Tunisia, the Tunisian Center for Public Health.
So before we get started, just presenting the Global eHealth unit I'm part of now. So it's a research hub for innovation and entrepreneurship in healthcare. We are a multidisciplinary team, or transdisciplinary. We collaborate on a number of national, international. We are also part of the WHO Collaboration Center in London. We try to develop evidence-based solution for healthcare using technology, basically. And our strong work is mostly on systematic review and evaluation of information technology implementation in low middle income countries, but also high income countries. And this is how I define it, the eHealth. And it's basically using tools and strategies not only to improve quality of care, but also expand it and create new dimensions. And this is what the discussion will be about later on. This is my strong belief that we're changing the way
Our strong belief.
That we're changing care, not only in the fundamental way we deliver it today, but also in the new ways of doing it.
All right, and I work for the Center of Animal Disease Modeling and Surveillance, and we are basically a multidisciplinary team from all over the world. And we work on emerging zoonotic diseases, basically diseases that move from animals to human and vice versa. And we try to help decision makers control and prevent those animal diseases or zoonotic emergent diseases. And we do that through data analysis, disease modeling, through a variety of tools, including mathematical modeling or network analysis, phylogenetics, risk analysis, basically. All right.
So this is probably the gist of our presentation. And we strongly believe that the health is a multidimensional ecosystem.
And you can see it throughout the room here. Everyone is from a field, basically. It's amazing. All right, so I'm going to tell you how I used to see things before starting my PhD. So I used to see them the left side, and now I see them all mixed up, like a shakshuka in Tunisia. And I will explain myself. So basically, if your dog is sick, you take it to the veterinarian. If your kid is sick, you take it to the doctor. If your farm is bad, then you call a specialist, an ecologist, basically. However, the truth is, it's all over the place, because actually, everyone gets sick at the same time. And because whether we like to go to nature and be in the environment with the animals, or actually the nature comes to us and the animals come to us, basically who takes advantage of that? It's emerging diseases such as Ebola or Zika. And basically the approach that we are looking at is animals' health, human health, and the environment are interconnected because we live in one world. And you have to look at the three of them at the same time, but also look at a a variety of external factors, cultural, social, political, economic. And actually, I wish we had some, of representative of these with us in this room. And if you want to get treated, understand these diseases, these outbreaks, basically, you have to take care of those three levels and the external factors at the same time.
So why is this multidimensional approach interesting to me? I'm being as a healthcare professional. The first element, we're going to just show some data. This is the healthcare spending in the OECD countries and comparing. So at the first slide, we might say this is a large spectrum from countries like US where healthcare expenditure around 20% to some other countries like India or Indonesia where the percentage is 1%. But the real picture is all these countries are sharing the same problem, the rising cost of the healthcare. So even though the starting point is different, we are facing the same challenges. The way healthcare is delivered today is not scalable, which means if we follow the pathway of high-income countries, the way healthcare was implemented in Europe, in US, or other countries, we won't be able to achieve universal health coverage for all population in the world. We cannot afford, we cannot provide the same health care to 6 billion people. And this graph shows basically the life expectancy in certain countries. Oops, what happened? Okay. Here we go. Okay, I'm not going to touch it again. But basically what we see is that there is a certain limit where scalability becomes the issue. Where life expectancy by sanitation or other concerns are rising in low and middle income country, but if we try the same pathway, we won't be able to achieve any of the outcomes or improvement of quality. And this is a huge challenge that my group is working on now. And our basic concern is that it's our only one-dimensional vision to healthcare, which focuses on biological research, for instance, and not taking into account social, animal, climate change impact, for instance, into our formula to define healthcare is a big issue. And one of the first tenets to this change is we need to understand what we are doing and to measure what we do. This is by Michael Porter. It was released last month. It's about the future of health. And he said that the first reason why we still take 17 years to diffuse innovation in healthcare is because we don't measure outcomes.
Right, so moving on to what we really do, we're not gonna be technical at all. This is fun, but we're gonna show you how we follow the multidisciplinary approach in our work, basically. So this is a work I've done on a highly pathogenic avian influenza in the United States. And, highly pathogenic avian influenza, from One Health approach, could be seen as affecting animals, human livelihood, and also the environment. And basically in 2014, 2015, the US went through one of the biggest epidemic of highly pathogenic avian influenza. This is a snapshot from This is a print screen from a disease bioportal that we designed, basically, and it helps decision makers see real-time outbreaks happening. And it basically, to summarize it, the outbreak hit 15 states. There was an increase in the price of eggs. There was a ban on poultry products from the US. Millions of jobs lost, and millions of dollars lost as well. So what we try to work on through this project is, can we predict areas at high risk for the outbreak? Can we create a map that could help decision makers do strategic preventive work, basically, targeted work? And very briefly, not technical, we worked on collecting data, free available data online. And we worked with ecologists, economic scientists, computer science to get those. And those are layers of population density and so on. We put that into a model that we designed that works through maximum entropy. And what it gets us is the contributing factors to the outbreak, but also a map, a visual map of areas at high risk. And the results were pretty cool, actually. we were able to detect 89% of the outbreaks that happen in the US, but also areas at high risk where there were no outbreaks. And now the decision makers in the US are using those maps to target these areas and prevent them from having outbreaks coming up.
So now about one other project then we focus on how we use multidisciplinary approach to healthcare. So one of the projects, my first project started at implementing what we call I2B2, which is integrating biology at the bedside and doing what we call translational research. So the basic concept today, we know that the healthcare is a producer of data. The healthcare by essence is a data-driven industry. So by 2020, we expect that around one patient will have around 1,000 terabytes of data available from clinical data research. And the basic concept is today, science is using poorly managed data. So most of the data we have, most of the insights are poorly managed. Most of the evidence are poorly used. And most of the experience is not actually captured. So we're missing a lot of opportunities, a lot of waste, and most harm to patients by not tackling this. And this is an important aspect on patient experience. So what's the strategy? Our first strategy, this is a paper we published by a group at MIT, and we looked at how can we transform the way we use the data and the clinical practice to respond back into a loop mechanism for clinical trials. And the idea was to use the post-marketing research phase as a way to improve clinical care using post-marketing research observational studies, which implement kind of what we call external validity. So we know that the gold standard is today clinical trials, but the problem with clinical trials, it's only valid within the context of the trial itself. So it's measured the same population, it measures a certain impact, but there is no external validity, meaning it doesn't take into account patterns of patient or physician prescribing medication, doesn't take into account a larger population or medication adherence of patients. So one of the research we worked on is how can we implement this technology and strategy. How we do it, we know that now they have research scientists on one room and clinicians on a hospital, and they are not connected. But what if we create an AHR-driven research where the byproducts, the information on byproducts and the biological materials accumulated through the delivery of healthcare could be used for discovery research and to study the healthcare system. So the project we implemented is basically connecting the first side, the left side, which is the clinical care setting, with the research side. And to enable that, we built this middleware, what we call the Translational Research Platform. It was worked over 5 years by a lot of scientists, and leading at Harvard Medical School, but other departments. And this is a general concept that has been implemented in a Diabetes Institute in Dasman in Kuwait, in collaboration with Joslin Diabetes Center. And the basic idea is transforming the way where we look into one silos, looking at the institution as the core, flipping the way around, looking to the patient as the core element, and then surrounding it by all members who are contributing to improving the care of the patient, including researcher, scientists, statistician, doctors, nutritionists, and all members. This work took 18 months, and it basically includes, as you mentioned, like you see KBHR, which is an electronic health record. There is a research pre-IRB process. We have a data quality improvement repository. We have a disease registry, and we created recently a biobank to collect automatically biosamples from patients. And it's somehow one of the largest research repository now in the Middle East. Another research, and this is just a new research that we started, where you collaborate with 3 different scientific departments. One group of statistics and science and system engineering at MIT. Another group are doing stem cell research. And another group were statisticians, were an epidemiologist working on primary care data in the UK. And the primary concept is, if we incorporate those methods all together, can we reach a new understanding of disease? The primary example of this is Alzheimer's disease. We know that now Merck, 2 days ago, just canceled their phase 3 clinical trial. Lilly, a month ago, just also canceled their phase 3 clinical trials, which basically is a result of 25 years of research that just collapsed. And one of the tenets of this issue is that all this spending is based on the scarcity of data. And if we use this multidisciplinary approach, we might define new phenotypic image and profiling of the disease of Alzheimer and probably new drugs. And this is supported by an NIH grant using computational research for drug repurposing. So, and there is new horizons. The healthcare, as we see it today, all the complexity are just expanding. There is a new precision medicine initiative, there is the brain research, and there is new models of delivery of care. I mean, the last one is an interesting project done by Possible Health in Nepal, where they developed a data-driven integrated care model of clinic in a rural area in Nepal. And they were able to succeed actually by providing more than improvement of life expectancy in the region and decreasing the rate of infectious disease, decreasing the rate of post-surgical infections, and creating the first partnership with the government of building a KPI-driven hospital, which means that the hospital is paid as a capitated model. If they improve the quality of care of the patient, they get paid. If not, it's their loss. And this is an exciting, really exciting project. They're implementing a state-of-the-art electronic health record system with a registry-based, using mobile technology and telemedicine in really rural areas where 10 years ago there was not even possible to build a hospital there. So with that, this is just a snapshot, an overview. We were just given 5 minutes, but
later, we'll keep the questions for
please,
later, right?
I mean, this is for engaging with the audience.
All right, thank you very much.
Thank you so much.